Welcome to part 4 of 4. For this section, we will discuss data collection and CRF completion, quality control, data transfers, and the data flow among the team and the sponsor. So far, we have covered source documents, CRF development, and database development. Now let's look at data collection. Original data generated from a research participant as clinically observed or directly from tests or devices is called source data, or source documents as we defined earlier. Data from these sources can be entered directly into a clinical data management system or transcribed onto a paper CRF and then entered into a database at a later date. The data in the database or on the CRF should always match the data from the original source document. Remember, notes from licensed providers serve as source documentation. For good clinical practice guidelines, investigators should ensure the accuracy, completeness, and legibility and timeliness of data reported on the CRFs, including all sections have been completed, all alterations have been properly made, all adverse events are fully recorded, and any specific documentation for serious adverse events has been completed. Ideally, CRF should be completed as soon after the subject's visit as possible to ensure the information can be retrieved or followed up on while the visit is still fresh in the healthcare provider's mind and while the subject and/or the information is still easily accessible. Anecdotal evidence appears to suggest that completions of a CRF, whether paper or electronic, within 2 weeks of a study event will help the research team to not fall behind in data abstraction. Some examples of common errors include logical errors, such as the date of the second visit earlier than the date of the first visit. Inaccurate information. For example, source document says one thing and a CRF says another. Omissions. An AE is recorded on the CRF, but not in the source document. Transcription errors, flipping the date and the month. Abbreviations. Unless using an approved list of abbreviations is distributed and utilized, data entry personnel often misrepresent abbreviations. There could be spelling errors, illegible entries or write-overs on paper CRFs, or writing in the margins on paper CRFs. Making corrections on CRFs. On paper CRFs, you want to draw one horizontal line through the error, insert the correct data, initial and a date the change. Do not erase, scribble out, or use any kind of correction fluid or any other means which could obscure the original entry. On electronic CRFs, you make the correction and the system does the rest. You may need to include a justification for why you made the change. Tips for completing CRFs. Use the CRF completion or instruction manual. Make sure appropriate protocol, investigator, and subject identifying information is included in the header. For studies in RDC, this should be pre-populated for you. Ensure the data is entered in the correct location or data field. Use the appropriate units of measurement for medications and labs and be consistent. Use only abbreviations authorized per your manual. Double check your spelling. Watch out for transcription errors. For example, you don't want to enter a sodium as 153 when it should be 135. Use the comment section to elaborate on any needed information, but please keep it to a minimum. Perform quality control checks and logic checks. For example, is the data consistent across fields and across CRFs? Make sure visit dates match dates on laboratory or other procedure reports. Make sure the date of birth matches the patient's age. Reminders. Data cannot be entered into a CRF if it is not in the medical record or another source document. If the individual completing the CRF finds missing or discrepant source data, they should notify the healthcare provider, who will then provide the data, or if applicable, contact the outside source, for example, the outside lab or a doctor's office. Now let's take a look at data quality assurance and data transfers. While there are many activities to ensure quality of data, such as monitoring and auditing, for this course, we will focus on discrepancy management. It is expected that data collected for a clinical trial is reliable, meaning it has few errors, to support data analysis. One way to ensure this is to measure the data quality and implement quality controls. For GCP guidelines, QC should be proactive and ongoing, applied at each stage of data handling, and ensure that all data are reliable and have been processed correctly. QC activities are performed by all members of the research team and the sponsor if applicable. Once data has been entered, has met the expected level of quality, and all discrepancies are resolved, data is entered into an analysis dataset using statistical software tools such as SAS or SPSS. data can be transferred or views can be created to provide the statistician with access to analysis. The analysis performed on the data can sometimes identify issues that an electronic data management system wasn't able to find. Many CDMS are designed to identify discrepancies by data point. However, it is generally easier for analysis software to view data across patients and across the study. Because of this, it is preferable that the statistician receive the data during the trial to identify any issues early enough before the trial data is locked. Data may need to be transferred to a sponsor from a site CDMS unless the site is entering the data remotely. This chart reflects how data generally flows from the site regardless of the sponsor. The site sees the subject, records the exam data on a source document. The site then transcribes source data into a CRF. The site does source document verification with a CRF. If no sponsor, the data can then be transferred to an analysis program. For paper CRFs, after data is confirmed, which may be during a monitoring visit, it is forwarded to the sponsor, where it is entered into the database twice by two different data entry coordinators. This process reduces the likelihood of human error in reading or entering the data. In conjunction with data entry, sponsors generally apply logic checks that are programmed into the data management software. For example, a check to confirm the patient's enrollment date doesn't precede the patient's birth date, or confirms exams were conducted within a protocol-specified windows, confirm the consistency of the participant's medical history throughout the study, etc. For remote data capture, the database will then perform logic data checks along with the sponsor's staff. A major responsibility of data management is to provide quality data for analysis, which entails identifying and resolving discrepancies. Identification of data discrepancies can be achieved electronically or manually. Implementation of electronic process will provide consistency and reliability to review data for possible issues. Most electronic systems include tools for communicating discrepancies or resolution, creating standard messages, and discrepancy tracking that can not only inform the staff which queries are open, but also the length of the time each discrepancy has been unresolved. If there is an automated system for discrepancy management, there are unique situations that require manual queries that are generated sponsor to a study coordinator at a site. It is important that these queries are clear, concise, and not leading the site to a particular response. A sponsor typically generates discrepancies either during or after a monitoring visit, or after a data set is sent to the sponsor and reviewed by the database. The site typically corrects the CRFs during or between monitoring visits. Database generated discrepancies are due to failure of entered data to pass a validation check as applied by a database. They may be univariate, meaning a single data element error, for example, not using a provided pick list or missing data in a field. Or they may be multivariate, meaning multiple data element errors, for example, a male patient with a positive pregnancy test. Let's take a closer look at data discrepancies for an IND sponsored trial. For sponsored studies, the flow of queries depends on if the site is using paper CRFs or remote data capture. For paper CRFs, the sponsor visually reviews the CRF data, performing logic checks. The sponsor generates data query forms and sends that to the site. The site responds to the query and returns the forms to the sponsor. The sponsor revises the database entry as necessary. For RDC, the database performs logic checks along with sponsor staff. The sponsor generates data query within the database. The site responds to the query, and ultimately the sponsor reviews the response and closes the query in the database. When discrepancies are noted, the sponsor will generate a data query form to ask questions of the site and provide traceability regarding data changes. As with CRFs, there are good clinical practices regarding who should complete these forms and how it should be done, as accountability and traceability for questions and answers must be maintained. This should be outlined in the DMP. Completed data query forms must be retained by the study site and by the sponsor to enable reconstruction of study data throughout the project and after the study is completed. Data is the foundation of research, but great analysis techniques cannot compensate for the lack of quality, quantity, or completeness of data required to answer a scientific question. The data in the database should always match the data in the original source document. Ideally, CRF should be completed as soon as possible after a subject's visit to ensure the information can be retrieved or followed up on while still fresh in the healthcare provider's mind and while the subject and/or the information is still easily accessible. We reviewed tips for completing CRFs, use a completion manual, make sure the appropriate protocol and headers are in the CRF, ensure data is entered in the correct location or data field, always use the appropriate unit of measurement and be consistent, and use only abbreviations that are authorized per the manual. Double check your spelling, watch for transcription errors, and keep comments to a minimum. Perform quality control checks and logic checks as you go along entering data. Data quality is critical. QC should be proactive and ongoing and applied at each stage of data handling, and it is the responsibility of all members of the research team. Let's ask two final questions. When should CRFs be completed? And who is responsible for data quality? Thank you for your time and thank you for joining.